bphtool.com. It was September in the fall of 2006. This reluctant 70-year-old cowboy came into my office. He was brought by his 4 family members who dragged him up because he was miserable with an IPSS in the 30s on his tamsulosin and finasteride for 10 years. His doctors had seemingly done the right thing, right? Defaulting him to the standard trial of drugs, more drugs, higher doses. At that time, triage and bladder health baselines were not talked about, but basic urodynamics would have shown that that bladder was struggling from his 200-gram prostate. I quickly booked him for surgery, and then the schedulers came to see me several days later to say that they had canceled surgery because he had died. You see, when faced with either the choice of a serious major surgery with morbidity and mortality or continuing his miserable life with an IPSS of 30s, he chose his preferred path. He took out his gun, pointed it at his head, and ended his life. What went wrong here? What could we have done better? And as we think about it, we salute the defenders of the Detruser, RAP, Hung, and Otta, who are fighting the good fight against stage 4 retention around Central America and South America, and they're reacting to the rise in more men showing up in late-stage BPH, BPO, and the question becomes, can we get ahead of this problem? Can we be proactive? And the answers lie with, how do we improve the drivers of good health policy? Yes, de-obstruction is important. Yes, dialogue is important. And the right data. More importantly, can we get more data, and does that help? When we look at the triangle of triage and we look at criteria that would trigger a bladder health baseline, one of them is unacceptable risk as seen by bphtool.com, a data-intensive cloud computing technology. We can use that at the table of shared decision-making, and then let's look at it and measure its degree of success against the 4 Ps of better personalized healthcare. bphtool.com went live 2022, 30,000 users, GSK Pharmaceuticals with their inherent bias, data science innovation hub, and we salute defender of the Detrusers, Grabus, for spearheading this project with personalized inputs, personalized outputs that create personalized risk assessments in a visually stunning fashion. And it came out of an era when we did not have many options for surgeries, right? Pre-1990, we had TWIP, TERP, open simples. And as a result, there was a perceived more favorable benefit to risk profile of drugs. And as a result, we saw a rise in prescription drugs and we saw a decrease in surgeries. bphtool.com is based on the combat trial, right? Drugs, more drugs creates more data, which we can use. 5,000 patients, drugs alone or in combination, we saw improvements of 6 points with bothersome symptoms and a 66% reduction in risk for stage 4 retention and or BPH surgery. Then they did a great job of elevating things to another level with even more data. They added the ARIA data from 3 placebo-controlled phase 3 trials for a placebo arm and more data for the dutasteride alone, reaching almost 9,200. And yes, this is not perfect. We are merging studies. It didn't have the MTOP studies. It did not have smaller prostates. So yes, it could be better, but once again, this is more data and it's easy. You just get online, personalized inputs, age alpha blockers, and all these basic urodynamic parameters. There's a slider that you can just adjust to customize the inputs to your patient. And it creates these great visually stunning outputs showing that, yes, with combination drugs, we can more readily decrease IPSS, reduce risk of stage 4 retention and BPH surgery. And you can drill even further. You can look at subscores, nocturia, quality of life, and lots of data. In fact, let's take a look at some. This is 3 men. They're all 65, moderate symptoms, slow flow in the empty well. 50, 80, 150 grams. When we look at the 4 Ps of better personalized healthcare, prevention, we can tell guys, look, with combination drugs, we can reduce your risk for stage 4 retention surgery from 13.5% down to 5%. Prognosis, Mr. Smith, I can tell you that with your 80-gram prostate, you're on tamsulosin, your risk of retention or surgery is 13.5%. Planning. Mr. Smith, let's plan to add dutasteride in combination because you've been on the tamsulosin, and if we add dutasteride, we can reduce your risk down to 5.1%. And so on the surface, it scores very well. It's personalized, it patient advocates, it plans, it prognosticates, and it prevents. Challenges are a lot of inputs. You need an internet and a PC, and it takes time to get all that information and talk to your patients about it. Works for some, maybe not for all. But more importantly, it allows us to have a dialogue beyond just what is unacceptable risk for retention and surgery, but also what is the role of drugs. And it speaks to our third mandate to prevent or end the polypharmacy epidemic. The COMBAT trial supports the long-term use of these combination drugs as a therapy. And the questions become, are we really preventing? Is it worth it? And as defenders, our answer is a resounding no, because it sacrifices a man's vitality. It violates one of our core elements of good health policy. Look at this litany of side effects. It contradicts our belief in practicing holistic medicine. I would submit that we espouse being minimally invasive, but in fact, we are maximally invasive when we give chemicals that touch every single cell in the body. Does it prevent? Well, if you take from speculative reasoning, take the 4-year data and draw out those lines out to 10 years, more than 1 in 3 on tamsulosin alone, more than 1 in 10 on combination drugs will enter into stage 4 retention or need BPH surgery. So with that, what we are really doing is just kicking the can down the road. We are sidestepping the issue. We are delaying care. This is a mechanical problem that needs a mechanical solution when warranted. At the right time, somewhere here within the window of curability, not down here. We need to stop pushing and kicking our patients further down into later stages of BPH, BPO. And you ask me, well, where's the proof? Show me something. Well, here's a study from 2018 retrospective looking at the impact of medications on surgeries. Approximately 100 patients per each of these years, 1990, 2000, 2010, looking at the indications and complications for these TURPs. And we see a shift of patients from early stages to the later stages of BPH, BPO. As expected, we see a rise in the number of medications, and we see a decrease of surgeries down to by 65%. As patients on drugs rose to 43%. And we see in 1990, there were 2/3 of those patients were having surgery for the indication of LUTs, early stage. Then by 2010, that was down to 26%. And now we're seeing the shift. In 2010, now 2/3 of men are having surgery for the indication of stage 4 retention. Even more concerning are those people who failed surgery and are long-term condemned to a lifelong of catheters, intermittent catheter, long-term catheters. It went from 2%, went up 6-fold to 12%. As defenders of the detruser, this is neglect of duty. And it's not our fault, I get it. It's just because we kind of mistook that drugs are treating when in fact they are temporizing. Remember, chemicals are not a therapy for a mechanical problem. They are an interim step. They stabilize the symptoms. They help us buy time to triage, to get bladder health baselines, to find the right treating mechanical solution to resolve the mechanical problem. We are not anti-drug. Drugs can be treating, just like antibiotics for sepsis. And similar to the example of brain tumor a la Defender or Gonzalez, BPH, BPO, the solution is deobstruction. Drugs and catheters are temporizing. So with that said, please stop narcotizing bladders. Do what we do well. We are solution-finding surgeons. We are not pill-pushing physicians. We are deobstructing urologists. We are preventative interventionalists. We intervene at the right time to prevent late-stage BPH, BPO. So please work together. Let's end the polypharmacy epidemic. I don't want to ever want to light another candle for another cowboy. BPHtool.com is very helpful and can be used for certain situations, not for everybody, to help triage and to trigger bladder health baselines. Choose data over drugs. End the polypharmacy epidemic, because drugs kick patients to later stages, are maximally invasive, and are temporizing. If you are prescribing drugs, that should trigger you to say, look, this patient in front of me right now needs triage. This completes part 2. I'll see you guys in the next one.